Thank you for the opportunity. I think I'm going to shift the focus from the lifestyle intervention to the hospital-based study here. So this is, we looked at the predictors. What are the predictors of the recurrent in-hospital hypoglycemia? So why in hospital hypoglycemia prevention is important? That's the biggest question. So in hospital hypoglycemia is a significant contributor of increased patient morbidity, mortality, and the length of stay. The etiology is multifactorial. It is preventable. That's why it is important to look for the hypoglycemia and look at the cause and treat the cause. So the aim of our study is to evaluate the factors associated with single versus multiple hypoglycemic events in a particular admission. Objectives. So we wanted to identify what are the clinical and the biochemical predictors of recurrent hypoglycemia, determine the primary cause of the hypoglycemia, and compare the length of stay for the single versus the multiple hypoglycemia. We also wanted to explore the implications of inpatient diabetes management. So methodology is, so it is a single center retrospective cohort. So we looked at the 75 patients with the hypoglycemia over a period of 8 months in 2023. We had a logistic regression model was created to identify the predictors of the multiple events. So the key results are the predictors. So if a patient had one single moderate to severe hypoglycemia less than 54 milligrams per deciliter, it increased the odds of the recurrence by 3.8%, 3.8 times. So we proved that the severity of the hypoglycemia is the strongest clinical signal for a single recurrence. So in our cohort, if we had the single, after our study results, if we had a single hypoglycemia, even if it is a mild from moderate to severe, we were more vigilant and started treating the hypoglycemia. So what are the causes of in-hospital hypoglycemia? The most common cause was inadequate carbohydrate if they are fasting. So reduced carbohydrate intake. We had more than like 41 events, the most significant contributing factors for the hypoglycemia. The next was the oral hypoglycemic agent induced. Most of them who were on sulfonylureas. And the other common causes were the patients with chronic kidney disease who were fasting, and notably the 10 patients had inappropriate insulin titration. If they had a hyperglycemia, they were treated with insulin, and it inappropriately, or the insulin dose might be higher, so they had hypoglycemia. What's the burden of hypoglycemia? At least like 69 patients had at least one hypoglycemic episode during that hospital admission. Nearly 46% of them had a single event, and 45% of them had a multiple events. So this is the hypoglycemic events stratified according to the age. Most of our elderly patients had a hypoglycemia, both single and multiple event. So the results on the length of stay, the average length of the stay was 2 to 3 weeks in both the groups. The length of stay, it had a substantial impact on the healthcare resource utilization. Length of stay is long regardless of the event frequency, whether they had a single or a multiple event. So that is quite important, because each of in Sydney hospitals, in Australian system, if they have a hypoglycemia, we call it as hypoglycemia hospital acquired complication, the hospital is penalized for the hypoglycemic event. So we really have to work hard and prevent hypoglycemic event. So the conclusion is, early involvement of the specialized diabetes care system is crucial, and need for the structured inpatient diabetes management model is has been established or has to be established. The targeted events around the nutrition, fasting can reduce the recurrence. Reducing hypoglycemia reduces, as I said, hospital acquired complications and improves the patient safety. So the current hospital strategies after this study, we established, hypoglycemia posters, and we had all those posters in the nursing's handover stations, so that with each handover, the hypoglycemia event will be discussed, and that reduce the hypoglycemic events. We had a patient special education for the junior doctors with a case-based discussion rather than just a generic PowerPoint presentations to identify the patients who are at risk of hypoglycemia. We reviewed our in-hospital hypoglycemia policies annually. So the future directions where the research and the practice should go next is we are in the process of building a risk prediction model. So once the risk prediction model is established, once a patient hit the emergency, so the risk prediction model will be rolled on and patients will be identified for the hypoglycemia and handed over to the inpatient team. And we are planning for intervention studies, and we moreover are going to integrate our automated EMR alerts. So we have a dashboard, so every single one diabetes educator will review the dashboard every day and alert the team. So these are our supervisors and acknowledgements. Thank you. I'm happy to have any questions.